And we are going to talk about the pancreas and its function within the endocrine system in this video. So the pancreas is going to be heavily involved in producing a lot of enzymes for digestion and stuff like that, but it is going to also play a really important role in the endocrine system. All right. So we're not going to talk about its digestive function in this particular video. We'll talk about that when we cover the digestive system in a few weeks, but we are going to focus on its endocrine system function here. So there are a lot of different cell types in here. A lot of them are going to make those enzymes, but we're focusing specifically on a couple key types of cells in here, alpha and beta cells. There are other cell types, delta and PP cells, so they are going to release some hormones also, but the two most important ones are alpha and beta cells. So we are looking around here at these what are called pancreatic islets. So these are a special type of cell that are surrounding these ducts, and they are going to produce their hormones and secrete the hormones into the ducts, and then the ducts will secrete them out further into the body. And so we've got some different types of cells here. Acinar cells, these are for digestive enzymes. Exocrine cells are going to be also secreting a lot of those enzymes. And then we have the endocrine pancreatic islet cells that are going to play a role in the endocrine function of the pancreas. The pancreatic islets used to be known as Langerhans or islets of Langerhans. That has been renamed, but they are secreting hormones glucagon, insulin, somatostatin, and pancreatic polypeptide, which is abbreviated as PP. So each type of cells in these islets are going to produce different hormones. So alpha cells are going to produce the hormone glucagon. They make up about 20% of each islet. Glucagon is going to play a really important role in blood glucose regulation. So low levels of blood glucose, so low blood sugar, is going to stimulate the release of glucagon because it's going to help increase blood sugar levels. Beta cells make the hormone insulin. These make up about 75% of each islet, and they are going to release that insulin when there are high blood sugar levels or blood glucose levels. Delta cells are only going to make up about 4% of these islet cells and secrete that somatostatin hormone. This is a protein-based hormone. This somatostatin is also released by the hypothalamus as growth hormone inhibiting hormone. The stomach and intestines are also going to secrete this, but this is an inhibiting hormone, and so when this gets produced, it is going to block the release of both glucagon and insulin. And then those PP cells are going to make up only about 1% of the islet cells, and they are secreting that pancreatic polypeptide hormone. It's thought to play a role in appetite, so being able to determine whether you are hungry or not. And it also seems to be involved in regulating other pancreatic functions for both the endocrine secretions and exocrine, so those digestive enzyme secretions. So we're not really sure exactly how it functions with those roles, but it does seem to play a role there. It can also get released following a meal, which can reduce food consumption, but it's also released in response to fasting. So we're really not entirely sure what exactly is going on with this pancreatic polypeptide hormone at this particular point in time. So here are those three main hormones that we're looking at with the pancreas. So that insulin, again, is going to reduce blood sugar levels. So its job is to help cells pull glucose out of the bloodstream. So they are going to act on whatever cells need that insulin. There are some cells that don't use that, so this hormone's not going to work on them, but all other body cells are going to require that insulin. The main cells are skeletal muscle cells and adipose cells. Those are the primary targets. So food being present in the intestines is going to trigger insulin production and secretion by these beta cells. And once those nutrients are absorbed, that surge in blood glucose, so that increase in blood glucose after digesting food, is going to cause more of this to be released, and then affect those cells that it's going to act on for them to start pulling glucose out of the bloodstream. Insulin is also going to help trigger the liver to convert any excess glucose into something called glycogen. Glycogen is our way of storing that extra glucose. So it's a really nice little storage package, and it's going to help convert that, any excess, into that glycogen. And then it can also help promote the creation of triglycerides and proteins. Secretion of insulin is, like many other systems in our body, regulated via a negative feedback loop. So as blood glucose levels go down, that is going to inhibit more of that insulin release. The glucagon hormone released by the alpha cells, this is going to do the opposite. It's going to help increase those blood glucose levels. So it is going to sense that decline, that drop in blood sugar. So this is going to happen during periods of fasting or prolonged exercise or some sort of physical exertion. So that glucagon actually has multiple effects. It's going to tell the liver to start converting those glycogen stores back into glucose. So that glucose gets released into the bloodstream to go to the body cells it needs to. It's also going to tell the liver to start collecting some amino acids from the blood and actually convert those into glucose. This is not the preferred way of getting glucose, but it will happen if we do not have enough of those glycogen stores. And it can also start triggering the breakdown of triglycerides into fatty acids and glycerol, and those can get used for conversion into glucose as well. So our body can convert both amino acids and glycogen, or not glycogen, fatty acids and glycerol into glucose. We have that ability, but that is not our body's preferred way of obtaining glucose. And then that somatostatin is going to prevent the release of both of those hormones, and that's usually going to happen when everything is at homeostasis, blood sugar levels are normal, and we do not need to be reducing or increasing those levels. And so we need to stop the release of those particular hormones. So the top endocrine system disorder, the one that most people are familiar with, is diabetes mellitus, and there are two main types of diabetes mellitus, type 1 and type 2. So type 1 diabetes is actually an autoimmune disorder where the immune system is going to attack and destroy the beta cells in the pancreas. So they're going to destroy these insulin producing cells. And so people who have type 1 diabetes are not producing insulin at all, because the immune system is destroying the cells that produce insulin. So they absolutely have to get synthetic insulin. There's a few different ways of doing this, but they really have to get that synthetic insulin regularly throughout the day and really keep a close eye on their blood sugar levels. So this is a very, very difficult condition to manage, because without that insulin, it's impossible to maintain proper blood sugar levels. Type 2 diabetes is going to make up about 95% of all diabetes mellitus cases. This is something that has what we call a genetic predisposition, which means that somebody's genetics can make them more likely to develop this condition, but it is not guaranteed that they will get it. It is lifestyle factors that ultimately determine whether or not those genes are turned on or off, triggering this disease to develop. So this is going to cause what's called insulin resistance, And so the cells that are normally going to be triggered by that insulin get less sensitive to it, so they're not as responsive to the effects of insulin, so they're not pulling that glucose out of the bloodstream the way they need to, because they're not being properly impacted by insulin trying to connect with them. And so the pancreas can start increasing that insulin secretion in an attempt to try to really force that to happen, force those cells to respond to it. But that's just going to basically tire out these beta cells too quickly, so they become exhausted and will slowly over time stop producing insulin. And this is a very slow process that happens over time. But eventually, type 2 diabetics will require insulin injections, just like type 1 diabetics. But in the earlier stages of type 2 diabetes, they are not necessarily going to require those insulin injections because the body's still producing insulin. It's just not acting on the target cells the way it needs to be. And the main way of helping to manage that is to work on diet and exercise, change those lifestyle factors that are making those cells resistant to the effects of insulin. Some of the early symptoms of both types of diabetes are excessive urination and excessive thirst. So somebody is going to be crazy thirsty and need to go to the bathroom a lot. And these are because of how out of control the blood sugar levels are, because too much sugar is going to impact the kidney function, because kidneys are going to help filter out any excess glucose from the blood. So too much glucose, too much of that sugar, is going to pull water with it out of the urine, and that is going to cause that excessive urination and also dehydration, making them incredibly thirsty and want to drink water all the time because that sugar is pulling the water out with it. So that's really, really dangerous. And this is also going to cause persistent hunger. So somebody's going to be really, really hungry because those cells are not getting that glucose in the bloodstream. Those high levels of glucose can also injure a lot of other tissues in the body, especially blood vessels and nerves, because we are getting a lot of inflammation in the lining of the arteries. This can increase the risk of developing atherosclerosis, so clogged arteries, increased risk of heart attack and stroke, damaging to the smaller blood vessels, the capillaries, and the kidney, can impair kidney function and lead to kidney failure. This can lead to blindness as we damage blood vessels that are leading to the eyes, as well as preventing blood flow to circulation in the limbs. Nerve damage can cause a loss of sensation. This is called neuropathy. This happens really commonly in the hands and feet. And because people are losing that sensation in their hands and feet, they don't notice when they have some sort of cut or injury, and then they don't treat that, and it can get infective and cause really, really severe infections and tissue death, which is why type 2 diabetes has a very, very high risk of amputations because of that damage. There's also a condition called ketoacidosis that can result from uncontrolled diabetes, because as the cells are not getting that glucose, they start relying more and more and more on fat stores. And that is going to force the liver to start using different pathways to get those lipids broken down, which produces something called a ketone, and these are very, very acidic. They're causing the bloodstream to start to become very, very acidic. This is life-threatening. If it's left untreated, it will lead to something called a diabetic coma, and people will very quickly die from this. So that is an absolute medical emergency, that ketoacidosis, the buildup of ketones, because that is going to be lethal. So this is something to really pay attention to. If you have a family history of type 2 diabetes, it's a good thing to kind of keep an eye on it. Like most things, you don't want to panic right off the bat, but it's a good thing to kind of keep an eye on your lifestyle factors and stuff like that, and do what you can to reduce your risk of developing it, because again, there is that genetic predisposition. Generally speaking, people who are type 1 diabetic, they're going to get diagnosed earlier on in life because that immune system destruction of the beta cells is going to start pretty early on in life. So this was previously referred to as juvenile diabetes, but it is entirely possible to get diagnosed with type 1 diabetes in adulthood. It's really just dependent on how long it takes the immune system to actually start destroying those beta cells, and for enough of them to be destroyed that it's causing all of these different symptoms. Type 2 diabetes used to be referred to as adult onset diabetes because it's normally adults that were getting it, but as a lot of children and teenagers are having higher weights and stuff like that, and there's more of those genetics out in the population, making people more likely to develop it. We are starting to see cases of type 2 diabetes popping up in juveniles, so people who are not adults yet. So it's not as accurate now to refer to them as juvenile and adult onset diabetes. We will continue talking about organs with secondary endocrine functions in the next video.